the chairman. Thank you, Topicon 25 organizing team. My talk is on retrograde nailing for distal femoral fractures and how to find an easy way to localize the entry point. Common fractures for retrograde nailing. The indications are ipsilateral fractures of the femur and tibia or bilateral femoral shaft fractures or in multiply injured patients. Simultaneous or sequential fixation of other fractures to save positioning time. Ipsilateral hip and shaft fracture to allow independent fixation of each fracture in an ideal way. Obese or very muscular patient or in patients with trochanter lipodystrophy. The contraindications are open growth plates, previous anterior cruciate ligament reconstruction, pre-existing hardware or prosthesis that would block a retrograde insertion of nail, incomplex open femur fractures due to the risk of infection into the knee joint. The standard operating procedure is flex the hip to about 30 degrees in supine position on a radiolucent table over a bolster and flex the knee to about 45 for easy access to the intercondylar area of the femur without damaging the patella and tibial plateau. It is a percutaneous approach, a 2 to 3 centimeter incision just medial to the patellar tendon or a patellar tendon splitting incision. Aim the guide pin slightly anterior to the PCL insertion. Insertion of guide pin. In AP view, the center of the notch, and in lateral view, centered just at the tip of the V formed by Blumenstadt's line. Drill the guide pin 4 to 5 centimeters into the distal femur. Entry portal is created with a cannulated reamer and the guide pin is removed. Implant-specific reamer is used to enlarge the entry point and to pass the long guide wire across the fracture. Common problems faced while passing the guide pin. Multiple image intensifier exposures to find the correct entry point in AP and lateral views. Guide pin may slip anteriorly into the patellofemoral joint or commonly into the intercondylar notch posteriorly. Guide pin may wander away from the desired point while drilling, getting stuck in soft tissue, needing multiple attempts in some cases, especially when the tip of the guide pin is not sharp. What is the way out? Use a 7 mm offset ACL femoral tunnel jig. Insert through the percutaneous wound into the intercondylar notch. Check the AP view. If it is correct, we found that in almost all cases, it is in correct position in lateral view. Drill guide pin through the jig up to 2 centimeters into the femoral condyles. Use a 4 to 6 mm entry reamer on this guide wire to drill a 2 centimeter deep entry hole and remove the reamer and guide pin. Introduce implant-specific reamer through the entry hole with no risk of slipping, and further procedure is same as in standard technique. Conclusions. Very easy to push ACL offset jig through a 2 centimeter skin incision. It gets easily locked into the desired position. It acts like a drill sleeve to pass guide pin through it without entangling soft tissue around it while drilling. Eliminates or reduces the difficulty to pass guide pin in correct place. Thank you.